If I were to tell you that there's an incurable condition going around, causing severe cerebral inflammation, progressive cortical atrophy, intractable seizures, and long-term cognitive dysfunction, you'd immediately think, God, not another complication of coronavirus.
The coronavirus.
But no, not coronavirus. At least, not yet. No, this condition is probably even scarier, although it affects inordinately fewer people in the world. And there's no obvious cause for it, no confirmatory test, and no cure. In fact, the only proven treatment is surgical resection of half the human brain, or a functional disconnection of the two hemispheres with callosotomy. Welcome back to Brainwaves, a podcast about neurology and medicine, and all the fascinating science and history that come with it. I'm your host, Jim Siegler, and this week on our program, the origins of and the latest insights into this rare neurological condition. Stay with us.
Hey podcast listeners, if you're a neurology resident and you plan on taking your boards this summer, you're probably asking yourself, how should I prepare? Well, you can start by checking out the annual Penn Neurology Board Review course, now in its 17th year. This high-yield course offers a broad range of online content, live in-person or teleconference discussions, and optional mock exams with up to 1,400 questions. If you're worried about COVID-19, the course offers more than 40 hours of video-based lectures and live streaming of the 2 days of case-based discussions, all featuring experts in the field. And if you're recertifying, you're also eligible for CME credit. So take a look at all that the Penn Neurology Board Review course has to offer by clicking the link in the episode show notes or just Google Penn Neurology Board Review course. Brainwaves listeners even get a special discount on the in-person and online content. Just use the promo code WAVES2020 at checkout. That's WAVES in all caps 2020.
Before we talk about the condition, I want to set the stage. It's 1958.
As 1958 began, America sent aloft its first Earth satellite, the Explorer.
So it was 1958, and the only diagnostic testing available for assessing neurologic function is the EEG and the X-ray.
As a matter of fact, X-rays are like ordinary light.
X-rays, these radiographs, had been discovered more than 60 years earlier, and they'd been in routine clinical use for more than a quarter of a century by 1958.
Late in 1895, Professor Wilhelm Conrad Röntgen first noticed the strange effect which led to the announcement of his discovery of X-rays.
Ironically, X-rays got their name from their still quite mysterious properties.
That is how they got their name, X for the unknown. Today, however,
And while these radiographs, or X-rays, gave us incredible insights into human anatomy,
The hot cathode X-ray tube.
really these images offered little information as to the structure of the human brain, largely because X-rays captured differences in tissue density. And brain tissue is not far off from cerebrospinal fluid when you consider the density of other tissues, like bone. But to improve the resolution of X-rays in neurodiagnostics, the American neurosurgeon Walter Dandy, who's known for his description of the Dandy-Walker malformation and for a number of truly revolutionary neurosurgical techniques, Dr. Dandy thought to remove CSF and introduce air into the subarachnoid space prior to radiography. These pneumoencephalograms, which Dandy described in 1918, would become instrumental in neurodiagnostics until the CT scanners emerged in the 1970s and 80s.
We're at 4 times a second. And you can see that halt.
So it was 1958, and pneumoencephalography is the one diagnostic test, short of basically open craniotomy, for which neurologists and neurosurgeons could visualize the human brain. In that year, Drs. Theodore Rasmussen and colleagues at the McGill University and the Montreal Neurologic Institute in Quebec described an unusual series of 3 pediatric patients with seemingly similar clinical and histopathologic findings. One of the patients underwent serial pneumoencephalograms, or PEGs as they were called, beginning at age 5, over a period of 6 years. At 5 years old, and having no prior illness or trigger for seizures, developmentally normal, the boy began to develop focal right-sided seizures and recurrent bouts of status epilepticus. He had been admitted several times over the years in an attempt to control the seizures, and he was found to have progressive right-sided hemiparesis. He underwent repeat brain imaging the whole time. 2 years after his first pneumoencephalogram, his first PEG, You could already see that the left lateral ventricle was beginning to grow. 3 years later, it dilated even more. And 6 years after seizure onset, with continued cognitive decline and persistent right-sided hemiplegia with significant homonymous hemianopsia, there was clearly significant atrophy of the entire left hemisphere. But what had caused this? What was responsible for this child's severe progressive hemispheric burnout? In their original report, Rasmussen and colleagues had also described the cerebrospinal fluid. The CSF was largely unremarkable. No evidence of infection or inflammation. In one of the 3 patients, a 1-year-old who was normal at birth and had normal development, the patient began to experience frequent recurrent focal seizures around 18 months of age. He underwent a gross frontal lobectomy involving the suspected seizure focus 6 months after he developed first seizures. Unfortunately, the patient continued to experience recurrent seizures and status epilepticus, and he eventually passed away around 4 years of age. But we are grateful to have learned from his case. Pathologists were able to compare the resected frontal lobe to the remainder of the brain at autopsy, and what they found was remarkable and perplexing. Admixed between normal neurons and glia were pockets of inflammatory cells, which seemed to cluster in the cerebral cortex, and there was also perivascular cuffing, findings that we know today are associated with infectious and inflammatory encephalitides. Now compare these findings to the whole brain at autopsy. The contralateral cerebral hemisphere, the side of the brain that was not responsible for the ongoing seizures and the disabling hemiparesis, that side of the brain was almost entirely normal. There were some lymphocytes in the meninges and the perivascular spaces, but grossly that tissue was fine. On the other side, the hemisphere was far from normal. Similar to the lobectomy specimen from 3 years earlier, there was now intense perivascular cuffing in both the cortex and the white matter in all areas. There were numerous scattered regions of inflammation throughout the cortex and the white matter, with polymorphonuclear and lymphocytic cells, and unlike the observations from the previously resected frontal lobe, there was now significant loss of cortical neurons with spongiform changes. Astrocytes had ballooned. And again, this was almost exclusively lateralized to one hemisphere, sparing the brainstem and the cerebellum. Our first patient, the 6-year-old who presented with seizures, had similar findings on histopathology. This was a child who was observed serially with the pneumoencephalograms, and his neurologists were able to discern the rapid hemispheric atrophy on that limited diagnostic test. The most that the kid had remained seizure-free was for 48 hours. At age 11, in an attempt to suppress the seizures and to slow the continued physical and cognitive disability, the patient underwent a radical hemicorticectomy, a removal of the diseased hemisphere, with the exception of the thalamus and the basal ganglia. Post-op, the boy experienced 1 seizure, but then a day passed. No seizures. Another day. No seizure. 3 weeks later, still not another seizure. And his IQ showed a small bump, 58, up from 53. 8 months later, he was in school and keeping up with classmates who had some degree of cognitive impairment. On review of the brain tissue from this patient's hemicorticectomy, the findings were remarkably identical to those of the other patient: cortical inflammatory nodules and perivascular cuffing with spongiform degeneration, and astrocytic hyperplasia. However, this child survived, so there was no autopsy to compare the diseased hemisphere to the other seemingly healthy hemisphere. In the third and the final case that was reported by Rasmussen, a 2-year-old, previously healthy boy developed a flu-like illness that was followed by a similar course of recurrent focal seizures and progressive spastic hemiparesis. As in the first patient, pneumoencephalography showed progressive cerebral hemiatrophy. He eventually underwent frontal lobectomy, followed by hemicorticectomy with resolution of his seizures and improvement in his cognition. The histopathology was identical to the 2 other cases. It's been 62 years since its original description of what's now referred to as Rasmussen encephalitis, and while the last 2 decades have led to an unprecedented enlightenment regarding inflammatory neurologic disorders, we still have not made much progress in our understanding of this drug-resistant inflammatory epileptic disorder of childhood. So what is Rasmussen encephalitis? Well, lucky for us, it's an extremely rare disorder that's isolated to the central nervous system. The estimated incidence is about 1 to 2 per 10 million people. More people have died from the measles in the last 2 years than the number of people who are diagnosed with Rasmussen encephalitis.
The death toll from last month's measles outbreak in Samoa had risen to over 60.
In fact, you need 200 times more people to develop Rasmussen before you start getting into those measles death numbers. And we have a vaccine for measles. Alright, so back to Rasmussen. The encephalitis that we see in these patients predominantly affects children and young adults, with a mean age of onset of 6 years, and it's characterized by three main phases: a nonspecific prodromal phase with focal seizures and a mild hemiparesis, and this can last weeks to years. Then follows the acute phase with frequent seizures and progressive cortical dysfunction, significant hemiparesis, hemianopsia, and aphasia or neglect. And the third stage is when the hemisphere has burnt out. The neurologic deficits have become permanent, but the seizures persist. Now, the formal criteria for Rasmussen encephalitis were proposed in 2005 in a European consensus paper. You can find it in our show notes. 3 cardinal criteria are required to make the diagnosis. First, focal seizures and a unilateral cortical deficit. Second, unilateral EEG abnormalities, which could be slowing or epileptiform activity. And third, unilateral MRI abnormalities, which can be T2 hyperintensity of the gray or the white matter, or T2 hyperintensity or atrophy of the caudate head. In the absence of any of these cardinal criteria, Rasmussen encephalitis can still be diagnosed if 2 of the following alternative criteria are met: A. Epilepsia partialis continua or progressive cortical deficit, B. Progressive hemispheric cortical atrophy, or C. Histopathology that's consistent with Rasmussen encephalitis on brain biopsy. Within months of symptom onset, patients will show radiographic abnormalities that are consistent with the disease. Hemispheric cortical atrophy and ventricular dilatation can be seen on either CT or MRI, with a propensity to involve the frontal and the insular cortices. Occipital lobe involvement is more common in severe cases and in younger patients, and invariably, the healthy hemisphere will show some degree of atrophy as the commissural fibers degenerate. Cortical restricted diffusion would be suggestive of frequent or ongoing seizure activity. However, deep gray restricted diffusion should raise your suspicion for an alternative inflammatory disorder, West Nile or rabies or something metabolic, but these findings are typically bilateral. A unilateral temporal lobe restricted diffusion can also be seen with certain infections like HSV1, HHV6, and prion disease, some vascular processes like an acute MCA territory infarct, metabolic disorders like MELAS, toxic processes like HIE or severe hypoglycemia, and seizure activity in the absence of CNS inflammation. We did a whole show on the unique causes of restricted diffusion, episode 154, but I don't think that we discussed Rasmussen because it's just so out there. But it's good to remind yourself of all the far more common reasons to see cortical diffusion and T2 abnormalities. So check out that show if you haven't already. Other than restricted diffusion, cerebral hemiatrophy has its own very unusual and short differential. And irrespective of the cause, whether it's Rasmussen's encephalitis or it's one of these other conditions, the symptoms are strikingly similar: progressive hemiparesis, cognitive impairment, refractory seizures. Non-progressive forms of hemiatrophy are thought to be related to some historic singular insult, a stroke in utero, genetic disorder, or trauma. Of the progressive hemiatrophy disorders, Sturge-Weber is a sporadic condition that's classically associated with that port wine state in the trigeminal distribution of the face, typically with imaging features that show leptomeningeal enhancement and gyriform cortical calcifications. The Dyke-Davidoff-Masson syndrome, which I actually saw a case of in med school, is an idiopathic developmental disorder that's associated with calvarial thickening and cerebral hemiatrophy. Another condition similar to Rasmussen is the Perry-Romberg syndrome, an inflammatory CNS disorder, but Perry-Romberg can be differentiated by its associated hemifacial atrophy, which is alarming, where tissues on one side of the face begin to degenerate, and there are subcortical calcifications, which we don't see with Rasmussen. Many patients with Perry-Romberg also experience trigeminal neuralgia, almost half of them, and migraines are not uncommon. But, like Rasmussen, Perry-Romberg is thought to have an autoimmune trigger, and it seems to be responsive to immunomodulatory treatments. Moving on to the other testing in Rasmussen, I've already mentioned from the original 1958 report that the CSF profile is typically normal, although CSF protein levels will go up as the disease progresses. So other than the histopathologic evidence that supports the immune hypothesis, those perivascular cuffs and the inflammatory nodules, what other science is out there? Well, some patients do have pathologic autoantibodies in their CSF to neuronal cell surface proteins. an antibody to the glutamatergic receptor GLUR3 was the first to be described in a clinical case of Rasmussen encephalitis. However, this antibody has not been found in all patients. Other antibodies have been identified in case reports and case series, like MUNC18-1, the nicotinic acetylcholine receptor, antibodies to the AMPA receptor, and many others. But the question remains, are these secondary antibodies, or are they truly pathogenic? And by that I mean, do these antibodies form as a response to cortical neuronal injury from some other mechanism, and now they're circulating in the serum or the CSF as a biomarker indicating CNS dysfunction? Or did these antibodies form spontaneously during perhaps a T-cell mediated autoimmune attack on the nervous system, and now they are part of this immunological battle against cortical neurons? There's a whole body of literature out there on the neuropathology that underlies Rasmussen encephalitis, and I'd encourage you to check it out on your own. I'll admit that most of it's way over my head as a clinician, but for those of you with an interest in basic science research, take a look at some of the references in our show notes. And if you have any ideas as to why, if there is this autoimmune origin, why is it that only one half of the cerebrum is affected? Aren't neurons and glia the same between the right and the left side? That was a question that my wife brought up, actually, and I want to give her credit for that insight. Other data that implicates an autoimmune-mediated process in Rasmussen is the fact that some patients actually respond to immunotherapies. The disease for some patients has become quiescent with plasma exchange or immunoglobulin infusions. Corticosteroids have also been backed by a number of successful observational studies. However, none of these therapies has been tested in a true randomized head-to-head or placebo-controlled trial. The most that we've done is compared outcomes in small cohorts of treated patients to historic controls, which, to be fair, seem like the treatments may be promising, but the data is hardly conclusive. Unblinded, non-randomized, single-arm studies. Other than the immunotherapies, which are being explored off-label and in ongoing clinical trials, many patients receive one, if not several, types of antiepileptics. Traditional AEDs like fosphenytoin and levetiracetam have almost zero efficacy in achieving seizure freedom for patients with Rasmussen, not unlike the response that we see in NMDA encephalitis. However, we do use AEDs in an attempt to reduce the frequency of seizures, to prevent status epilepticus, and maybe even slow the cognitive decline by preventing cortical neuronal burnout. But this is just a theory. Ultimately, hemispherectomy remains the most effective therapy for the prevention of further seizures and the prevention of long-term disability. More than 3/4 of patients with this extreme approach achieve seizure freedom, although many parents and providers are conflicted with the possibility that removing the left hemisphere, for example, could result in long-term irrevocable language dysfunction, permanent vision loss, or hemiplegia. In spite of these risks, earlier treatment when the condition is milder, experts say, has been associated with cognitive stabilization and neuroprotection of the healthy hemisphere. While fewer seizures are generally better for the brain, and this can be achieved with some degree of anticonvulsant use or immunotherapy, the most definite means of achieving seizure freedom and improving long-term neurologic outcomes is early and aggressive surgical intervention. And like we would do for temporal lobectomy, assessing for language lateralization with the WADA can give you a good sense as to whether the patient's an ideal candidate for that hemisphere to be surgically resected. Younger patients are more likely to show a good response to hemispherectomy when compared to older patients, as language function may transfer between the hemisphere that was destined to become dominant to the hemisphere that was not, following surgical resection. The healthy, non-dominant hemisphere can pick up the slack, so to speak, if hemispherectomy is performed earlier than 5 or 6 years of age. Now, a quick word about adults with Rasmussen encephalitis before we wrap up the show. A while back, I was asked to review the case of an older gentleman with a really unusual neuroimaging finding. Eventually, the radiologist called it consistent with Rasmussen encephalitis. The gentleman was of late middle age, had vascular risk factors, polysubstance abuse history, including narcotics and benzodiazepines, and he was found unresponsive. He was intubated in the field. There was a concern initially for seizures, so he was managed in an intensive care unit for a few days before healthcare staff had realized the right side of his body was not moving as spontaneously as the left. A brain MRI was performed, which showed a large hemispheric diffusion abnormality, which they'd originally interpreted as an acute stroke. However, there was no clear cause of the stroke, and on repeat MRI, there continued to be this progressive diffusion change that had spread across the MCA territory, and it eventually involved the parafalcine and the occipital cortices, ACA and PCA territories. More than a year later, he never recovered function in the affected arm or leg, and his aphasia persisted. But repeat MRI continued to show that diffusion abnormality, and the fact that there was this progressive necrosis of the cortex that extended beyond the MCA territory and spared the contralateral hemisphere without an identifiable cause for infarction raised one radiologist's suspicion for Rasmussen encephalitis. Now, could it have been? In one review article, published in 2017, the author summarized all 102 reported cases of adult-onset Rasmussen encephalitis. There were only 102 known adults in the world with this condition, and 2/3 of them met those earlier formal criteria that we mentioned, proposed back in 2005. Of these 102 patients, most were women, about 80%, with an average age of onset in their 20s. So still young people. Half had a comorbid autoimmune disease, which, to be honest, probably raised the clinician's suspicion for an autoimmune encephalitis or Rasmussen's, and I'm sure it led to a publication bias. Most patients in the cohort presented with refractory seizures at onset, and often without any antecedent neurologic history, and the progression of symptoms was slower than what was typically observed in children who have Rasmussen, and these patients responded more consistently to immunomodulatory therapies. The authors concluded, and my takeaway from this article was that your differential diagnosis should remain open, especially when there's an unclear, seemingly inflammatory CNS disorder leading to new onset seizures and progressive cortical dysfunction. So workup for autoimmune encephalitis, including Rasmussen encephalitis, should be pursued. And a trial of steroids or immunomodulatory agents could be considered, as earlier treatment is known to benefit a wide range of autoimmune CNS pathologies. But we still have no idea what it is we're treating, and it's probably something like ESUS in stroke, or NMO spectrum disorder in transverse myelitis. That this condition, this Rasmussen encephalitis, likely represents a heterogeneous spectrum of probably related conditions. And until we have better data, experts recommend treating it as an aggressive autoimmune process, which invariably leads to serious disability and refractory epilepsy if untreated. That's all for Brainwaves this week. Thanks so much for joining us. Could that last patient I brought up at the end have had Rasmussen encephalitis? Well, yeah. He met the European consensus criteria. But again, Rasmussen is a clinical syndrome. There's no biomarker, no formal test. Other causes of encephalitis still ought to be excluded in the workup for these patients: HSV, anoxic brain injury, influenza, maybe even COVID-19. We still have a lot of work in that regard. The episode this week was produced by myself, Jim Siegler, out of Studio 3, safely secured and socially distant from others in the heart of Philadelphia, Pennsylvania. Music for our program is courtesy of R. Sonor, Daniel Birch, John Watch, Lish Grooves, under a Creative Commons license. Our theme song was produced by Timothy Dalton, sound effects by Mike Koenig and Daniel Simeone. And if you're taking your neurology board exam this summer, I strongly recommend you check out the Penn Neurology Board Review course, which I took in preparation for my licensing exam. It was an excellent prep for the exam, and even if you don't live in Philadelphia, you can still access the wealth of the online content, the pre-recorded lectures, and an optional mock exam from your home. Use the promo code WAVES2020, and you'll even get a discount at checkout. So click on the link to the registration in the show notes to our program to get more information. I'm Jim Siegler. Talk to you soon.